Heart failure, cardiomyopathy, and other disorders. CHF is congestive heart failure, biventricular failure. It is so common they've just determined to call it heart failure. But you'll still see it referred to as CHF, and because that's the most common. It is a chronic disease. It is progressive in nature. It is the most common hospital diagnosis for those people over the age of 65. There are about 500,000 new diagnoses each year in this country, and that is down from 550,000, so we're making some progress. But the 5-year mortality rate is still 50%. These statistics are from 2008. The text identifies them as 60% male and 45% female for mortality. It also states that we should have about 25 million patients who have CHF by the year 2015, and that's only 5 years from now. 80% of all patients with CHF are over the age of 80. By the way, this is part 1 of this lecture. CHF has a direct cost of $19.4 billion per year, and an indirect cost in lost productivity, mortality, and morbidity of $21 billion a year, for a total of $38 billion a year. That's a lot of money. And when you're looking at medication costs, 2001, the Heart Association estimated that they cost about $1.6 billion a year, and since that was from 2001, I have a feeling those statistics are a little bit higher now. But if you have one chronic condition, it'll cost you about $196 a month to treat that. If you have 3 or more chronic conditions, it'll cost you about $519 a month. And if those conditions are COPD, diabetes, and heart disease, that's anywhere from $520 to $557 a month. And now we have people who are deciding, do I buy food? Do I pay rent? Do I pay for my pills? It is a major concern. 30 to 50% of our readmissions within the first 90 days are considered preventable, and in many instances will not be reimbursed by the government. There are different types of heart failure. Right versus left heart failure, there's a table on 458 that lists the different symptoms, and the concept map for them are on page 457. Acute versus chronic has to do with the speed of onset and the degree of compensation. Forward versus backward, if it's forward failure, you have a problem with aortic stenosis or systemic hypertension. If it's backward heart failure, your ejection fraction is less than 30%, and you have an increase in your pulmonary artery pressure. Systolic versus diastolic is very difficult to tell by symptoms. You need to do an echocardiogram in order to determine whether it's systolic or diastolic heart failure. If it's systolic heart failure, you have a decrease in cardiac output. You may have somebody who's had a heart attack. If it's diastolic, they'll have a stiff heart, and they may have like a cardiomyopathy. You can also have a functional decrease in contractility, which will cause heart failure. The New York Heart Association functional classification level is one that everyone throughout the country has decided to utilize so that we are standardized in the way in which we're referring to our patients. Class 1, there is no physical limitation on activity because there are no symptoms. It's more like the doctor knows that they're at risk for this and so forth, that they call them a Class 1. Class 2, they'll have symptoms that go away when they rest. There'll maybe be a slight limitation in physical activity. The patient will complain of fatigue, dyspnea, palpitations, or angina. Class 3, they're getting into serious trouble now because minimal activity will cause symptomatology. Their activities will be markedly limited. They'll be comfortable at rest, but ordinary activity will lead to symptoms of heart failure. And Class 4, symptoms at rest. These patients do next to nothing because any activity leads to increased discomfort. The compensatory mechanisms that go along with heart failure Adrenergic, you have an increase in blood pressure. You have peripheral vasoconstriction and with shunting of blood to your vital organs of the body. The renin-angiotensin-aldosterone system is kicked in because the kidneys are not getting the blood supply they expect. So they'll start to retain fluid, they'll increase sodium water reabsorption, they'll decrease the metabolism of aldosterone, which will lead to an increase in your antidiuretic hormone levels, and this will cause an increase in fluid volume. And this will make the person sicker, because now we have more fluid that they have to pump around. But it is considered a compensatory mechanism because it's done in an effort to improve, even though it doesn't. There is a figure on page 461 that will talk about these. The patient will develop tachycardia. Now initially that's okay because that will increase their cardiac output, but that will quickly lead to an increase in workload, an increase in their oxygen demand, and a decrease in their ventricular filling. And that will probably lead to cardiogenic shock. Ventricular hypertrophy does this initially is okay, but it also will lead to an increase in workload, an increase in oxygen demand, a decrease in ventricular filling, and cardiogenic shock. It is also associated with pre-existing hypertension. Ventricular remodeling is when the ventricle reshapes and becomes a round bowl shape and then doesn't contract as well as it's supposed to. And that's why we give ACE inhibitors or angiotensin receptor blockers and aldactone and beta blockers to decrease that remodeling that occurs. There's a chain of complications that goes along with heart failure. Initially you'll have dyspnea, then orthopnea, which is positional changes, shortness of breath. Paroxysmal nocturnal dyspnea, when you lay down, your lungs fill with fluid and you can't breathe. And you lay down during the middle of the night, so you wake up just really short of breath. Cardiac asthma, pulmonary edema due to an increase in capillary hydrostatic pressure. Respiratory alkalosis initially, because you increase your respiratory rate, blowing off more CO2. And then that will lead to acidosis and hypoxia and ventricular dysrhythmias because of the decrease in oxygenation. When you manage CHF, the major goal is to control their symptoms. And they want to control the symptoms by decreasing your fluid volume overload, giving morphine. Morphine causes blood to pool in the extremities, decreases peripheral vascular resistance, decreases anxiety. Decrease your systemic vascular resistance by giving vasopressors and nitroprusside, vasodilators, not vasopressors, vasodilators, such as nitroprusside, nipride, or nitrates. And you want to increase contractility by using an intra-aortic balloon pump that's also called counterpulsation. This will increase your coronary artery blood flow as it's inflated during diastole. There's a picture on this on page 535. It contains a picture of the waveform found in someone with an intra-aortic balloon pump and a picture of the mechanism of action of an intra-aortic balloon pump. And waveforms are listed on page 536. IV inotropes can be used, but they do increase the workload and have been shown to increase mortality. So they're not used initially. And ACE inhibitors are used. You'll find nursing diagnoses listed on page 463 for heart failure, and those for somebody who's using an IABP on page 535. As I said, the waveforms are also on page 536. Medical management, you want to correct the cause. Sometimes they'll do this by doing what's called a dynamic cardiomyoplasty, where they wrap the latissimus dorsi muscle around from the back, around the heart, and then put like a pacemaker on that muscle and stimulate that muscle at the same time the heart is contracts, so it squeezes from the outside, which will artificially increase your cardiac output. That's the dynamic cardiomyoplasty that's listed there. Patient teaching is a must. You have to have their cooperation. They have to agree to limit fluids, to limit their sodium, to gradually increase their activity, to comply with their drug regimen. Because if they don't do those sort of things, it will not work. A myomectomy is where they go in and they remove part of the myocardium, making the chamber smaller. Contraction will be stronger. This goes along with Frank Starling's law. Ventricular assist device takes over the pumping action of that ventricle. Oftentimes is done as a bridge to transplant. Can also be done as a terminal destination. Heart transplant, only cure. Give them a new heart. And medications. And we'll be talking about all the medications that may be given a little bit later. Evidence-based practice, collaborative, you'll find on page 465. Cardiomyopathy, there's a picture on page 466 that shows the different types that are there. One of them is now called hypertrophic, used to be called IHSS, which stood for idiopathic hypertrophic subaortic stenosis. In other words, the ventricle got enlarged and the area under the aorta got very, very tiny. So it was really hard for the heart to pump any blood out through that opening. This is genetic. The way in which to treat it is to decrease the patient's activity, put in an implantable cardioverter defibrillator, decrease the size of the septum, which would increase the size of the chamber, because it's the muscle that's getting hypertrophied and closing off that area. So if you cut some of that out, that'll open. Giving them calcium channel blockers or beta blockers will help. Dilated cardiomyopathy is now congestive cardiomyopathy, and it's heart failure. And so they get heart failure treatment, such as a ventricular assist device, dynamic cardiomyoplasty, and myomectomy, as we talked about in the drugs. Restrictive cardiomyopathy, again, this is genetic. You have very small chambers. The treatment for this is to decrease their fluid intake, decrease the sodium in their diet, give them beta blockers, diuretics, or cut out part of that septum. For any of the cardiomyopathies, the only cure is a heart transplant. And there's a box on page 467 that discusses the patient teaching that needs to be done. Pulmonary hypertension, pulmonary arterial hypertension, can be idiopathic or primary. 34% of the people who develop pulmonary arterial hypertension survive about 5 years. Idiopathic means it's unknown, but it could also be a genetic cause. It tends to have an insidious onset. It can also be secondary to respiratory hypoxemia for people who have COPD, sleep apnea, or interstitial lung disease. Dr. Hegde, who used to be the chief of staff and was an excellent cardiologist, internist at St. Charles, developed primary pulmonary hypertension, and he almost made it the 5 years. Very smart man, very nice man. Pulmonary venous hypertension is due to an elevation in your left ventricular end diastolic pressure, secondary to coronary artery disease, myocardial infarction, HIV, or cardiomyopathy. You diagnose pulmonary arterial hypertension or pulmonary venous hypertension by doing an echocardiogram or a right heart cath. The echo will show the hypertrophy of that heart muscle. Treatment of pulmonary hypertension, calcium channel blockers can help. Prostacyclin has been shown to help. It vasodilates the pulmonary vascular bed. It controls the symptoms. It prolongs life. There are different types. Epoprostenol, or Flovan, is given IV. Treprostinil sodium, or Modulin, is given sub-Q. And Bosentan or Tracleer is given orally. Your phosphodiesterase inhibitors have been shown to work particularly with your females. And this is your Viagra and your Celexa that we're talking about here. But with any of these, they have to be on anticoagulation. because with Coumadin, because blood is not circulating as well as it's supposed to. The concept map for pulmonary hypertension is on page 471. Your nursing diagnoses are on page 472. Your patient teaching is also on page 472. Evidence-based practice is on page 473. Endocarditis is due 75 to 85% of the time due to strep or staph infection. There's a box on page 475 that lists the signs and symptoms and predisposing factors. Treatment is long-term antibiotics. We're talking minimum 6 weeks of IV therapy. If it occurs with a prosthetic valve, you have to replace that prosthetic valve. Used to be called subacute bacterial endocarditis. Now, not all types of endocarditis are due to bacterial infection. Anything that causes an infection can cause endocarditis. It has a 40% mortality rate. Endocarditis is diagnosed with a chest x-ray, an echocardiogram, or a TEE, and your major complication is a stroke. Nursing diagnoses are on page 475, and your evidence-based practice is on page 476. Valvular heart disease, there are two types, stenosis or insufficiency. Stenosis is trouble with the valve opening. Insufficiency, incompetence, regurgitation, prolapse, all the same thing, mean you have a valve that doesn't close appropriately. There's a table on page 477 to 478 that talks about the pathophysiology and the symptoms for each type of valve disorder. Medical management, you want to treat it with, treat the symptoms of heart failure, replace the valve, do a valvuloplasty or balloon dilatation. Patient you'll hear either a systolic or diastolic murmur depending upon where it is located and whether the problem is stenosis or insufficiency. Nursing will need to assess your patient, get a daily weight, INO, medications, administer the appropriate ones, and teach your patient about the process. And you'll find your collaborative care on page 480. Aortic aneurysm, there are pictures of this on page 481 and 482 that talks about the different types of aneurysms and dissections. You could have one that's saccular, that means it's outpouching on one side. It's like a Barry aneurysm. It could be a fusiform, which involves all layers equally. Dissecting involves only one layer. And a false aneurysm tends to be when an artery has been punctured and then plugged with a clot. If it's 4 centimeters or less, they are taught to lose weight, lower their blood pressure, and only follow medical treatment because the major cause of aneurysm formation is hypertension. If it's 5 centimeters or greater, surgical repair. Symptoms of dissection, severe hypertension, neurological deficit, aortic insufficiency murmur, acute pain. If the ascending aorta is involved, cardiac tamponade. Those evidence-based practice on page 483. Remember, your abdomen can extend really easily, distend really easily. Think about Thanksgiving and Christmas, and probably your birthday. But if your aneurysm leaks anteriorly, you're going to bleed out in like 20 minutes. If it leaks or bleeds posteriorly, you've got about 24 hours to get that surgically repaired. So if you have a druther, you're going to have your aneurysm leak posteriorly because the spinal column puts some pressure there and prevents it from bleeding out. Nursing care, morphine for pain control, blood pressure bilaterally every hour, peripheral pulses, heart sounds on monitor. You're looking at that every hour. They should have an arterial line in. They get labetalol, IV, 2 milligrams per minute. Now this is both, it's a non-selective beta blocker, so that means it does beta 1 and beta 2. And it's an alpha blocker. The beta blocker will decrease contractility. The alpha blocker will vasodilate, so it will help to lower that pressure a lot. And you'll have onset in 2 to 5 minutes. You'll do a neurovascular assessment every hour that looks at the 5 Ps: pain, pallor, paresthesia, paralysis, and pulselessness. There's a box on page 483 for your collaborative treatment of this. Peripheral arterial disease is an arterial occlusion due to atherosclerosis. You get symptoms when it's 75% occluded. You'll have intermittent claudication, which means it gets better and then worse. The pain is relieved with rest. You'll get pain at rest, and you could have an acute occlusion. Now, an acute occlusion, you'll have pallor, pain, the extremity will be cold, there'll be no pulse, they'll have impaired function. Anytime you have pain at rest or an acute occlusion that threatens the viability of that limb, it has to be taken care of right away. You'll have your hair loss, dry skin, thick nails, temperature changes that will develop over time, and it will progress to gangrene. You'll need to check your ankle brachial index. In other words, you check your blood pressure at the ankle and your blood pressure at the arm. And you subtract your ankle blood pressure, you divide your ankle blood pressure by your arm blood pressure. It should be 0.9 to 1. If it is 0.71 to 0.9, you have mild peripheral arterial disease. 0.41 to 0.7, you have moderate peripheral arterial disease. And if it's below 0.4, you have severe peripheral arterial disease. Nursing diagnoses you'll find on page 485. Peripheral arterial disease medical management, you want to eliminate the risk factors. Foot care, anticoagulant or antiplatelet treatment, vasodilators, percutaneous transluminal angiography, stents, bypass. There's a box on page 486 that talks about collaborative practice. And this is where we're going to stop for part 1. We'll resume part 2 in just a little bit.